So this is Rhett again, continuing my overview of ECGs. Here's my very amateur attempt at writing a exaggerated ECG waveform, but it'll be enough for you to get the idea of what I'm talking about. So first thing I'm going to do is just label the important waves and intervals. Now I'm not going to be covering everything, but I'm going to be covering, just like I said, the very basics for you when you start out on the ward. So as you should know, this is your P wave. This downward spike is going to be a Q. This is an R, and this is an S wave, and this is your T wave here. And what I'm going to do in these videos is I'm going to basically be going through this in a temporal fashion and saying what are the things you should be looking for in each section of this ECG. So between these 2 points, this is your PR interval, and that starts at the, an interval will start at the beginning of the wave and to the end of the wave. So you're looking for PR like that. For your QT interval, that starts at the beginning of the Q wave and extends to the end of the T wave. Then you have things like your QRS complex, so that'll be like this area here. That includes Q, R, and S waves. And the other probably important thing is to know your ST segments. Now, ST segment, that actually starts at the end of the S and goes to the beginning of the T. So this is a segment between the two waves. This is an interval, which is inclusive of the two waves. So the first thing you're going to want to look at when you look at an ECG is the heart rate, or you can call it the R to R interval. So say this is your second R wave. The time in between the two peaks of the R waves is your R to R interval. And if your heartbeat is regular, that should be equal to the heart rate. So one thing you should, I'll tell you right now about that is that if you have more than 100 beats per minute, that's defined as tachycardia. Less than 60 beats per minute is bradycardia. Now, if you read Dubin's, he has a method for quickly calculating your heart rate, and that's to use the 300, 150, that's 150, 100, and then he goes 75. 60 and then 50. And basically this technique is to say in between the number of big boxes, you basically find an R wave that spikes at the tip of a big box. And then you say, all right, how many big boxes are in between this and the next one? And if you have, if there's only one box, then that is equal to a heart rate of 300. If two boxes is 150, three boxes is 100, and so on. If it's between, say, 3 and 4 boxes, you could say, well, this patient has a heart rate of between 75 and 100, but I know it's not over 100, so I know it's not tachycardia. So if you, and I just want to say, like, that's a really good method for looking at ECG quickly, but it only works if the rhythm is regular. If the patient has an irregular rhythm, you cannot use this method. You have to basically add up all your R waves and then divide by the amount of time, and that'll give you the heart rate. Okay, so let's start going through the actual waves. So the P wave here, I don't have a lot to say clinically about the P wave directly, except you should just know that that is, when you're looking at a P wave, you're looking at atrial depolarization. Your PR interval, that's, so like I said, that's that wave. So your PR interval, that is going to tell you a lot about what's going on when the signal is starting from the atrium until it depolarizes the ventricles. And that's what's represented by the QRS complex. So there actually is a lot you can tell about this area right here. I'm going to go quickly through the different kinds of heart block. I'm not going to do a lot of writing on it, but they are some things you should know. So this PR interval, this should be between 120 and 200 milliseconds. So about 3 to 5 boxes, I guess, long. If it's greater than 200, by definition, you do have first degree heart block. So, and 200 is equal to 1 big box. So if you're really confused, you just find a big box that starts at the beginning of the P wave. And then if you see that, the R wave is past a big box, you know that they have heart block. So there's actually 4 kinds of heart block. It's actually confusing because the naming schema is a little weird, but just in general, you should know that the higher the degree of heart block, the further down the problem is. So first degree heart block is a problem with the sinoatrial node, and basically the only thing going on in first degree heart block is that this PR interval is greater than 200. It's usually a benign issue. It's usually an issue with electrolyte imbalance or some sort of drug toxicity. So if you have a patient who looks healthy otherwise but has this extended PR interval, you might want to do a tox screen. You might want to check their electrolytes and see if something like that is going on. They do not need further cardiac intervention. They don't need to be admitted to the hospital. If you see someone with second degree heart block, there are 2 kinds of second degree heart block. And basically second degree heart block is when one or more atrial impulses, an impulse that starts from the atrium, doesn't make it to the ventricles. And there's 2 ways that happens. So type 1, which you might hear called Wenckebach, that's where the PR interval continues to get longer and longer and longer until there's a drop beat. So you have P, QRS, and then you have P, QRS, and this interval is going to be like 0.08 seconds or something, and then it gets to be 0.12, and then it's 0.16, then 0.2, then 0.24, and then you have a drop beat. And then it starts again at 0.1, 0.06, or 0.08 again. That's an example of type 1, where it gets longer and longer and longer, drop beat, and it's really short again, longer and longer and longer, drop beat. That's almost always a benign disease. It's usually a problem with the AV node again, the AV node as opposed to the SA node, and it's usually benign. Again, that's an issue where you should be aware of it, but it's not something that you would need to do further cardiac intervention. That's in contrast to actually second-degree heart block type 2, which is an impairment of the His-Purkinje system. So in that sense, the signal is getting from the SA node to the AV node, and then there's a problem below the AV node, and that's what happens when you get you just get a drop beat and there's no change in the PR interval. So your PR interval will be 0.18, 0.18, 0.18, and then you have a drop beat. That's 0.18, 0.18, 0.18, drop beat. So then you might actually start seeing things like, 2 to 1 or 3 to 1 or 3 to 2. That's where you get those drop beats. That actually is an indication for intervention because that can progress to third degree heart block. Third degree heart block is also known as complete heart block. That is where there's an impulse generated in the SA node and it does not get to the ventricles at all. The ventricles will depolarize on their own. It's sometimes called an escape rhythm. Basically, the ventricles act as their own pacemaker. So the way you'll see that on an ECG is you'll see regular P-to-P intervals. So if you take calipers out and you measure this distance, and then this distance to the next one, they'll be the same, and then you measure the R-to-R intervals and they'll be the same, but these have no relation to each other. So the way I like to say that, when you're interpreting ECGs, you'll look at it and say, like, is there a QRS after every P wave? Is there a P wave before every QRS? And if that is not true, then they likely have third degree heart block or complete heart block. And we'll continue this in the next video with the QRS interval.